سعدني طبعا اقدم اخويا وصديقي الاستاذ دكتور عبد الله شاب من الامارات. وعبد الله احنا مع بعض هيستوري من زمان، ومن ايام ما فكرت انا حتى كنا بننظم مع بعض الكارديو ارب، وده كان اول فكره عملتها ان يبقى فيه ارب سامت. وهو الحقيقه هم قدروا من خلال النشاط بتاعهم ان هم يعملوا الجلف انترفنشن سوسايتي، والحقيقه اتس ا فيري اكتيف سوسايتي وخدت مومنتم قوي وبقت اقوى سوسايتي في الريجن في الانترفنشن. وانا طبعا النهارده يعني المره دي هو الجيست اوف اونر بتاع المؤتمر، واحب طبعا اهنيه. وهو عشان اللي ما يعرفش كمان هو نائب رئيس الجي اي اس ونائب رئيس الجمعيه الاماراتيه، يعني هيستوري طويل في الفيلد اوف كارديولوجي والفيلد بتاعنا. وانا بشكره ان هو جه معانا رغم ان احنا كل اسبوع الحقيقه بنتقابل في حته في الرياض وفي البتاع، بس هو المره دي جه، وان شاء الله يستمتع بالاقصر ونستمتع معاه بالمحاضره بتاعته القيمه. شكرا.
السلام عليكم ورحمه الله وبركاته. دكتور عادل شكرا جزيلا. دكتور خير عبد الدايم اشتغلنا مع بعض في العرب بورد، حقيقة كان شرف لي أنا أكون مع الدكتور خير عبد الدايم. يسعدني أكون معكم. الدكتور وائل كان موجود هنا وقال لكم يعني the blue zone. سمعتوا عن blue zone؟ هو يعني he said that having omega 3 or that, but really if you look at the real behind that is four things. One of them is called hara hachibu. Hara hachibu, this is the Okinawa people in Japan. They practice this. They eat until they are 80% full. So the question, how can you make sure that you are 80% full? هو يعني الأكل باعتدال. يعني I think they practicing what we learn by Prophet صلى الله عليه وسلم. ثلث وثلث وثلث. They practice that. هم أيضا they eat with the family and their friends. عاد اليوم خذنا في جولة جميلة جدا ريحنا. That kind of environment make you have a purpose in life. So that's the third thing. The fourth thing is to be physically active. So I think if you practice that and sleep well, you inshallah live long. طيب نرجع لموضوعنا. How to manage dyslipidemia in a personal way. I mean, that means I have to stay away from all the guidelines and all the studies. طيب. This case, I think, is straightforward. You know, middle-aged patient coming with CCS, Dr. Islam, CCS, troponin normal. This patient did not have a CT scan because patient doesn't like to be having, you know, something like CT. We challenge. So what should we do? I don't do stress. Okay, so patient, this was the case, you know, so we can see the lesion, two critical lesions. The way I deal with these cases are different than others. I try to keep the lesion as native as possible. So I prepare the lesion. Lesion's fine, then I leave it. I will not put a stent. I put a drug-coated balloon. So this was the case for this patient. But the question is, this was the LDL, 140. So that's the reason patient having this atherosclerosis. And this is atherosclerosis built on many years. I don't think this atherosclerosis happened like day. That has been building many, many years. So what brought patient to the hospital? زعل مع زوجته. Something happened, okay? So patient came to the hospital. So now you're going to treat this immediately and within seconds. What we do normally as a new generation, when they open the artery, they want to open it in 10 seconds. That's wrong. Putting a stent 10 seconds, that's wrong. This should respect these arteries, should be done a proper way. Anyway, go back to the LDL, 140. So what we are aiming to bring, what's our target for LDL here? 50% or more, صح? Or less than 70. So this patient, you know, this was the dealt with this patient. But anyway, we as a physician, we are not dealing with LDL. Everyone talk about LDL today, and we have hypertension, we have inflammation, we have diabetes, we have obesity, we have many things to deal with. It's not one thing, but we have to prioritize things. According to events, cardiovascular events, coronaries, dyslipidemia plays the highest role. But of course, you have many things. You have diabetes, you have hypertension, you have many things. But If you want to take, something prioritized, then focus on LDL. Bring it to a target, then focus on others. We can do them all if you have the time. And this is based on randomized clinical trial, genetic, observational studies, animal studies, all supporting this. طبعا في social media they say to you there's no link, but this is not true. We as a physician, we should focus on evidence-based. Many trials, I don't want to go through this. It tells you that there's a high link between the two. صح? Yeah, we all agree to that. And we've already seen this. And this is why we say risk stratify our patient. If you show them this, you show your patient this to be personalized. Forget about the population. Your patient, you show them, look, you are here, you are here, and you are here, and we are aiming here. If you do that kind of practice, it take you about 30 seconds, 1 minute, then patient know where to go. So, a question for you now, okay? So you just to warm you up. And do you know what attention span of a human being nowadays? Between me talking to you and you go to your mobile, how many seconds? كم تتوقعون؟ In 2000, the attention span was 12 seconds. Nowadays, 2024 is 8 seconds or 8.23. So really, our span attention is losing. Our young generation, that's why you see them on mobile. I was on a mobile most of the time. So attention is not there anymore. But anyway, look at this question. So what do you think the most appropriate for patients to avoid events in future? I think Dr. Ashraf and others, they talk about this. It's not just treating that LDL, bring it down, it's to continue. How to do that? That's the magic. How to do that? That's the question. It's not just one day. We've seen this. And you can see the lower and you stay for a long time, the better and less getting. But all of us are going to have events. All of us are going to have events. But to delay that with a good quality of life, that's what we want. So this is the interplay between the patient, the physician, and resources. Try to convince. And that patient who had already event is much easier than the patient who had not event. Primary prevention is very, very difficult. Very difficult. So we have all these tools to do that. We have a statin, we talked about that. We have the ezetimibe, we talked about that. We have the other non-statin. Then we have PCSK9, then we have inclisiran, then we have apheresis, then we have many things to come. I think if you sit with Dr. Ashraf and the rest, they talk to you about the new things coming in future. That's not our job now. Let us use what we have nowadays. Okay? Many trials coming, and you've seen this all. We have these 4 things to do, and if you do it properly and do it in a nice way, according to your resources, then most of the time you're fine. Most of the time you need only statin and ezetimibe, most of the time. But that needs some kind of convincing from us as a physician to speak to that patient in front of us in a right way, nice way, to believe in us, because they are bombarded with the social media 24 hours. You only have 5 minutes to speak to them. That time is spent in a nice way. And instead of giving him more medication, convince him, convince her in a right way. I think that's what we do. The problem we're facing every day is the guidelines. It's changing. Every time they take them with a different level. We're going from, we used to have 120, then we went to 100, then 70, now 50, now 40. Same happened to hypertension, same happened to diabetes. That's the problem. Of course, the guidelines, they look at resources, they want the best, but again, you're dealing with the patient in front of you, and you have to be realistic, okay? We've seen, despite of all this evidence, randomized clinical trial is something, real life something else. Randomized clinical trial, patients are adherent. They have to be adherent, otherwise will not go to the medication, to the trial. That's why you see them, they get to the level, they get to the target. Those in real life, they are not adherent. That's why they're not getting to the target. Easy. That's the reason. Medication work, but if you don't take it, it will not work. So it's not a magic. So this variability, they always show you about it to stay away from statin. I don't believe in it. I don't think that's right to that extent. Why this working in randomized clinical trial doesn't work in real life? Anyway, so this is the trick. If medication not taken, they need to think about something else. So we have other tools. These 2 tools available. Very expensive, unfortunately. And I don't know when they become patent to be generic. I don't know. I heard the generic is available in Egypt for everything, but I hope they have it for this as well. So what we need is not intensity of the medication itself, and bring the LDL down today or tomorrow or 1 month. No, we want adherence. So that's more important. So if you have, of course, intensity and adherence, that's great. But if you have one of them, adherence I want, even with little bit. Okay, that's much better than intensity and forget about it. Only take it. I mean, if you sit with your patient, they tell you, doctor, I don't take my medication twice a month. No. To be truthful with you, twice a week. Then well, every day I don't take it. Yani if they really like you, they tell you the truth. I think that should be our thing. I mean, this is the evidence that intensity and adherence are the best. But if you want something better, then adherence is enough. We've seen these guidelines. Okay, there are many of them available. There's the American, European, Asian, Middle East. We have all our own. Okay, but the best thing is try to give a patient a medication, either combination or a medication that patient take for life as much as he can. Don't give medication because I want intensity and that's it. No, give him medication the patient can take and for life. You see, that's the beauty. A medication you get it twice a year or once a year or once for life, much better, of course. That's what we want. We as a physician, myself, I take antibiotics, I never finish it. I only take it for 3 days or 2 days. I don't finish it 7 days. If we as a physician don't do it, do you think the patient will do for a medication has no symptoms? Do you think so? I mean, it's not that easy. But in randomized clinical trial, this is what happened. You get them up to that kind of adherence to the goal, these patients. So that we need to think as a physician, as a government, is to provide these medication which are helping the adherence, this expensive medication. It needs a work of everyone. It's the work of we as a doctor, we as as a pharmaceutical companies, and being persistent with that, of course. So the past and present challenge, I think I leave it this for Dr. Ashraf and Dr. others to find a solution for these patients. These patients are difficult. It's a minority. Don't talk to me about this in front of cardiologists who are busy. These are for the expert. This is another day we can talk about it. Okay? So a patient like this, LDL 60, getting calcification, Dr. Islam, why? 60. The LDL is very low. Or 80, you can say. Why getting calcification? So must be something else is going on. So this patient, I had to go with something like this, inclisiran, and you see a rapid reduction. Same apply to this patient, who are a young man having acute coronary syndrome. Again, LDL 140. This patient, to be already on 2 medication, atorvastatin and ezetimibe. This patient is not tolerating, getting a non-adherence, so I have to find a medication which bring the LDL in a nice way. Inclisiran was doing a great job, and in 3 months and 6 months, patient started to leave the statin and others because I know he was not adherent or her not adherent. This is another case. So there are many cases I can show you. We have evidence from UAE, people who get acute coronary syndrome, their LDL even 80. 80, they get in. What do you want to do? You want to bring their LDL to what? 40, 30? Yes. That should be the aim. But patient not adherent, what can I do? I have to find a solution for this patient. So there are many barriers. These are all the barriers: adherence, access, and prescribing. I think we all face with that. So it's very difficult to treat as asymptomatic problem. Polypharmacy is the problem. You don't want to increase their medication, and concerned about the safety always there with the new medication, of course. So what I suggest to do is to aim for low, stay low, and adherent. So aim for low, stay low, and adherent. I think that should be our way. And I think I finished on a good time. Thank you very much.
Thank you, Abdullah. But I just want to ask you, في difference between when to start treatment and what level you should reach. So if you find, as you said, this kind of calcification and the LDL is 60, what will you do? Will you start treatment?
Yes, this is what I did for that patient.
Yes, I know, but I mean, we usually refrain from using heavy doses. What will you use? Low, moderate dose, high dose? What would your target? 40, 55? What's your target?
So that patient already, you can see there are soft and non-calcified plaques. So they're diffuse 2 places, at least 3 places there, and patient not having symptoms. So I went according to guidelines. I started with 2 medication, 40 by 10 combination. And I found patient not adherent, and LDL not reduced even. It went, I think, 50 after a few months. So this patient, I started inclisiran. That's why patient went down to 10, I think, later on. so I mean, I have to do, one thing about inclisiran, they're claiming, of course, I don't know, is happening. They say the plaque is reduced. Dr. Ashraf is here. Dr. Ashraf, you've seen that? They say the plaque, the components, it become more, even the calcification, they think about, is that one also, because statin will increase calcification, because change the soft plaque to the hard plaque. But the inclisiran is different, works in a different way. This is what they're claiming, I don't know.
Abdullah, thank you very much. We have advisory boards about the using PCS9 and inclisiran, and we suggest, because the economy is not like your country, but actually even in Europe, you ask in Europe, it's not easy to give every patient PCS9. Do you think that it's time to start, even the patient develop myocardial infarction, that you have to use, or a secondary event, to use triple therapy for the patient? It's called extreme risk from the start, rather than to wait for the number?
I did that, and we have, if you come to Abu Dhabi, we have three centers already started that. It's difficult, from insurance to get reimbursed, but in the government is fine at the moment. We did that, and you get a great reduction in their LDL and the adherence. That's the thing. I think a statin will work, ezetimibe will work, but the problem is adherence, doctor. That's the only thing. Otherwise, you see randomized clinical trial show us they work very nicely, and most of them, they get to the target. But if you come to real life, no, it's not, because of the adherence.
أنا أولاً عاوز أقول كلمة عن الدكتور عبد الله شهاب، لأن أنا أعرفه من سنين، وهو صديق لمصر يعني، وهو رئيس الزمالة العربية، البورد العربي في الكارديولوجي اللي سبقني، يعني أنا استلمت منه واشتغلت معاه 2 سنين، وأنا أشهد أنه هو في خلال هذه السنتين كان في غاية الكفاءة والحيدة يعني البراعة في ظروف. طبعا العمل على النطاق العربي أصعب بكثير من العمل على النطاق المصري يعني، وهو كان يعني أشهد أن أنا سعدت بالعمل معاه لمدة 2 سنين دول يعني.
تشرف دكتور، حفظك الله.
نعم، سعدنا أن نشوفك في مصر.
بشكر دكتور عبد الله، وبشكرك على الحضور وعلى المحاضرة القيمة.